Section 3. Assessment, Insertion, and Maintenance. Protecting the line.
Once we have played detective and selected the absolute perfect device for the patient, we enter the physical phases of care. This whole life cycle represents how we protect the patient, how we protect the line itself, and frankly, how we protect our own professional integrity. Assessment and insertion today are, of course, heavily reliant on ultrasound technology. The exam tests your knowledge of two primary ultrasound methods. First is the in-plane approach. This is where you align the ultrasound probe completely parallel to the needle. It gives you this beautiful, full visualization of the entire needle shaft and the tip as it advances through the tissue. It is fantastic for precise depth control. Then you have the out-of-plane approach. This is perpendicular. On the screen, it shows the vessel as a dark circle, and the needle tip just looks like a single bright white dot. To do this safely, you have to use what's called the walk-the-probe technique. You are constantly making micro-movements with the ultrasound to track that tiny bright dot. If you don't, you run a huge risk of puncturing right through the back wall of the vessel. Choosing the right depth is also super key here. Ideally, you're looking for a target about 0.3 to 1.5 centimeters below the skin surface. Too shallow, and you risk a messy through-and-through puncture. Too deep, and your visualization gets really muddy and dangerous.
And when it is finally time to actually insert a central line, infection prevention is absolutely 100% non-negotiable. The exam is going to test you relentlessly on the standard bundles used to prevent CLA-BSIs, central line-associated bloodstream infections. Step 1. Anatomy matters tremendously. The subclavian site actually has the lowest infection risk because it's a relatively flat, dry environment with less mechanical movement. The internal jugular is next, and the femoral vein down in the groin, that is the absolute highest risk. It's a dirty, high-movement area that we try to avoid if possible. Step 2 and 3. Your skin prep is a solution of 2% chlorhexidine or CHG in alcohol, and you must use physical friction. You scrub that site actively for 30 seconds. And step 4, this is the step people constantly rush in the real world, but you absolutely cannot rush on the exam. Allow it to dry completely. Why? Because if you puncture the skin through wet CHG, you literally drag liquid alcohol straight into the patient's bloodstream, and you completely negate the chemical barrier you just tried to create.
But what happens when things go wrong during the maintenance phase? The exam loves to give you troubleshooting scenarios, particularly around line occlusions. Imagine you walk into a room, you go to flush a line, and you meet solid resistance. Rule number 1, you never, ever force it. Instead, you have to rapidly play detective again and identify which of the 3 types of occlusions you are dealing with. First, mechanical. Is there a kinked catheter under the dressing? Is there a closed clamp you missed? Or is the catheter tip wedged up against the vessel wall? Second, chemical. Did someone recently infuse incompatible medications that formed a literal crystallized precipitate inside the line? Or third, thrombotic. Is there a fibrin tail hanging off the tip, a fibrin sheath covering it, or a solid intraluminal blood clot? If it is a thrombotic occlusion, your critical next intervention is requesting an order for a thrombolytic agent. Specifically, the exam wants you to know about alteplase. That's the drug used to break down the fibrin, dissolve the clot, and save the line. Recognizing these 3 types instantly is a huge part of scoring well in Domain 1.
Section 4. Communication as Clinical Intervention. Building Trust.
Now, a lot of technically gifted, brilliant clinicians really struggle in this next area because they view communication as just some fluffy soft skill. But on this exam and in reality, interpersonal communication is a vital, highly testable clinical intervention. Just like flawlessly flushing a line or applying a perfect sterile dressing, the exact words you choose to use have direct, measurable impacts on your patient's outcomes, their anxiety levels, and their compliance. When you are securing informed consent, you obviously must communicate the risks honestly, but you have to do it without inducing sheer terror. Think about it. Walking in and saying, "Hi, I'm here to place a central line near your heart, and you could get a lethal bloodstream infection," literally spikes the patient's heart rate. It triggers refusal based entirely on panic, not facts. Instead, you need to frame the why and immediately pair that risk with your active prevention strategies. Try something like, "Your care team wants to give you medications that are just too strong for the tiny veins in your hand. Now, there's a small risk of infection with this larger IV, but we use a maximal sterile technique, daily cleaning protocols, and strict monitoring to protect you." Do you see the difference there? You are actively building trust. You are framing the medical device as a helpful solution to their problem, rather than a terrifying threat.
Teaching proper device care to your patients is another huge focus on the exam. We really need to use vivid, visual language and make major health literacy adjustments. Avoid the medical jargon completely. Don't say central venous catheter. Tell them it's a long IV that ends near your heart. And I absolutely love this next quote. Your dressing should look like a clean window. It's so simple. No fog, no moisture underneath, no lifting at the tape edges. This is exactly how you empower your patients to monitor their own care safely. You also want to use the teach-back method. That's where you ask them to explain the care instructions back to you in their own words, just to confirm they actually got it. And we always have to ensure cultural competence. Here is a major test point. If a patient does not speak English fluently, you must use a certified professional medical interpreter. Never, ever use a family member to translate for informed consent. Family members might intentionally filter bad news, or they simply might lack the complex medical vocabulary, leading to incredibly dangerous misunderstandings. The exam will definitely test you on that boundary.
Section 5. Evidence, Ethics, and Law, the Professional Standard.
All right, this section is the professional standard that separates the basic technician, the person who just knows how to physically place a line, from the master clinician who knows why we place it, when to absolutely refuse to place it, and how to protect their professional license. Evidence-based practice, or EBP, is frequently tested conceptually as a three-legged stool. To make a truly sound clinical decision, you must perfectly balance three equal parts. First leg, the best available evidence. This means intimately knowing your major guidelines, like the INS Standards of Practice, the SHIA Guidelines for Infection Prevention, and the MAGIC Guidelines for Device Appropriateness. Second leg, your clinical expertise. This is your personal technical skill with the ultrasound probe and your pattern recognition from years of practice. But the third leg is what always trips people up on the test: patient values. A patient's cultural beliefs, their home support system, and their personal fears are weighed just as heavily as the clinical research. If an adult patient with full cognitive capacity explicitly refuses a medically necessary PICC line because of a severe phobia, the core ethical principle of autonomy dictates they have every right to do so. Your job in that moment is to educate, document the refusal thoroughly, and escalate to the provider. Your job is never to force or coerce the procedure.
You also have to remember that legal and ethical standards govern the entire ongoing life cycle of patient care. It doesn't stop after placement. Day 1 is, of course, all about determining patient capacity and getting that informed consent, fully disclosing the risks, benefits, and the alternatives. But as time goes on, say by day 3, and honestly every single day that a line is physically inside a patient, you must document a daily necessity review. If a provider tells you they want to leave a central line in just in case they need it later, but there are literally no active medication orders requiring central access, evidence and ethics strictly dictate that you advocate to pull that line immediately to prevent a VABC. And heaven forbid, if a severe adverse outcome happens, let's say a guide wire is accidentally retained inside a vessel and requires surgical retrieval, that elevates to a sentinel event. That means it must be formally reported to the Joint Commission, or TJC. You are operating as part of a massive interconnected system of accountability.
Let's talk about something that makes hospital administrators and lawyers immediately sit up straight: manufacturer's instructions for use, commonly known as IFUs. On the exam and in life, IFUs are legally binding documents. They aren't just polite suggestions from the company. The IFU specifies exactly what a device can and cannot handle: its maximum PSI for power injection during a CT scan, its specific flushing volumes, and its chemical compatibilities. If you make the clinical decision to use a device off-label, for example, using a midline catheter to infuse a vesicant medication that is explicitly outside of its approved IFU, and the patient suffers a severe extravasation harm, the legal liability transfers entirely away from the manufacturer and lands directly on you and your facility. The exam desperately wants to verify that you understand your legal boundaries and the profound, career-saving importance of operating strictly within your defined scope of practice.
But look, we work in healthcare. We know that when humans are involved, bad things do occasionally happen. How do we react when they do? The exam thoroughly tests your understanding of quality improvement and the root cause analysis, or RCA process. If your hospital unit suddenly sees a huge, unexpected spike in PICC line occlusions or a cluster of CLAB size, an RCA is initiated. The absolute crucial takeaway here is that an RCA is entirely about systems improvement. It asks what exactly happened, and then it repeatedly asks why it happened by tracing the workflow back step by painful step. Was the flushing protocol written unclearly? Were the needleless connectors we purchased defective from the factory? What a proper RCA absolutely never does is assign personal blame or seek to punish an individual staff member. It is fundamentally about fixing broken, flawed systems so that good, well-intentioned clinicians can do safe work.
Wow, we have covered a massive amount of ground today, haven't we? From the meaning of the NCCA accreditation to the physics of the 33% vein ratio, all the way to the heavy legal weight of an IFU document. I want to leave you with a final, provocative thought that really synthesizes everything we've just learned. Imagine you get this exact scenario on exam day. A patient with advanced chronic kidney disease, or CKD, is admitted to your floor and they need just 3 days of IV antibiotics. The attending doctor puts in an order for a PICC line. What do? Well, if you're just acting as a task-oriented technician, you probably just grab the ultrasound and place the PICC. But as a VABC certified clinical detective, you rely on evidence-based practice. You know that the KDOQI guidelines explicitly state to avoid placing PICCs in advanced CKD patients in order to preserve those precious arm veins for a future life-saving dialysis fistula. You also know that 3 days is considered short-term therapy. So, what's your move? You use your expert communication skills to call that provider, you advocate fiercely for the patient's future, and you recommend a standard peripheral IV or midline instead. In that one scenario, you matched the tool to the task, you protected the patient from future harm, and you upheld the absolute highest standard of care. And my friends, that is exactly how you crack the VABC exam. Thank you so much for joining me on The Explainer today. Keep studying the evidence, and I will see you next time.